Welcome to the Orthopedic Indications channel, where we discuss medical education for medical sales consultants and reps. All right, let's move on to a little more challenging case. Bethany, this is your case. This is a patient late 70s, if I remember right, and has a fall with an open ankle, left open ankle medially, I believe. And she gets close reduced in the ER and X-fixed and fixed the medial malleolus by one of our trauma partners. And then you get to manage it additionally. So
she had a pretty large open wound, and I was told that the skin was awful and her whole situation was awful. So I think we had talked about doing a nail for her for that because of her skin situation.
But I think this one poses some additional challenges. Just it's more comminuted than some of the others. So in terms of getting and maintaining length was not necessarily as straightforward as one would hope in this particular situation.
Yeah, it was tricky, but I think that there was still some ability to maintain length. She has this little bit of a butterfly fragment, but on the very distal aspect, it was going to hit the second. I mean, it was only two pieces, and then it had this butterfly. So I thought that there was still an ability to maintain length there.
Yeah. So lateral incision. I mean, yes, you had an incision because you got the weedy in there, and then you got the two clamps on there, which looks like it lined that up pretty well. To your point, I don't know. I think are these from a bump? All the staples there, or something on the leg.
Yeah, I don't really remember. No, they were from I cover my X-fix holes with a little bit of towel and IOBAN.
Got it. I was like, I don't think she had a free flap as I was going through the X-rays.
Yeah.
Okay, so you're able to get it clamped and get it out. Like the length looks pretty good in this situation.
Yeah.
And, we were talking about getting and maintaining length. I found this article. This is by Calvin Rushing in Dallas area, I think. And this is just a kind of, this is actually free online if you want access to it. And in this particular article, he was showing some different strategies for getting and maintaining length. Obviously, you see the clamp there, but he was using the Hinterman or Weinraub or K-wire distractor to actually get and maintain length. If you can keep your pins out of the trajectory of your nail, I think would be the biggest challenge. But I thought this was kind of an interesting article or interesting strategy that you can use.
So I do that all the time. The one really nice one to do that on is actually those shortened transverse fractures, because you can put the two K-wires in, lengthen it out with the Weinraub, and dock it into itself, and then it stays, which is awesome. So I use that as a reduction tool a lot with my the transverse or the pilon fracture, fibula fracture.
Yeah, I just thought what was interesting is using it here with the nail system as well. But you got to keep your wire out of the trajectory.
Well, it's not only that you have to keep your wire out of the trajectory. I don't know on some of these systems, even with the clamps, maybe you can talk about clamp placement and that guide. Sometimes it gets in the way. The guide that goes on the nail, the external guide.
Yep.
You have to talk about clamp placement or this thing. I mean, you slide the nail up and that external guide just jams right into it, which is super frustrating.
And this looks like a nice, it's like using a femoral distractor on it, but a fibular distractor. But the thing is, you're right, with the guide, that's just going to get in the way, right? You're not going to, at least I've not used it. I like it. It's a nice.
Put it anterior. So
yep, I agree with that.
I would put it anterior almost.
And the same thing, if you look at the clamp placement on the picture in the kind of bottom, the clamps are down, and you got to get the clamps pointed towards the head as well if you're putting the clamps on. And I didn't point that out on the previous case, but you see it here in the case Bethany's doing. The clamps are headed towards the head for that exact reason. You got to keep them out of the way of the outrigger. All right, but I agree. Put them towards the top, anterior, and then keep them out of the way. So here you see clamps pointing towards the head, guide wire going in. Everything's holding pretty good through this whole case here. And you can see the difference in the design technique. If you're not familiar with fibular nails, you can see there's a threaded proximal segment to this particular nail. I'm assuming, I didn't even go back and look, Bethany. I'm assuming that was was that a 4-5 intramedullary nail that you were using? I think they come, this one's 3-5, 4-5.
Yeah, probably. Maybe. I would, this is the flower. So you have to I will tell you when you're using it, watch your fracture because you screw it in like a screw. So the fracture can like rotate and turn, especially if it gets a lot of intramedullary, like canal bite, whatever. It can get a little hard and you're like turning it, and then all of a sudden your fracture's not how you had it.
But that's where I think making sure you ream, taking the time to ream, even if you think there's a big canal or the bone's not very good, I still think just going through the practice of reaming it to make sure that you can facilitate passage of the nail, because that will be the challenge with it.
So I got a question. How do they have different size threads? Like, do you have like a 3-5, 4-5 driving end?
3-5, 4-5, and 5-5, I believe. And I believe that's like the diameter. I don't know if there's that's a good question. I don't know if there's a difference in the threads from one to the next. I don't know if anybody's on that could answer that or not. But there are differences in terms of the diameter of the intramedullary implant.
Gotcha.
Okay, so then advancing the nail, and kind of to the point, talking about placing your syndesmotic fixation, dialing in your rotation, check a lateral to make sure you like it before you buy it. This one, you don't have to deploy anything proximal. So once you get it to where you think you like it and you pin it, you're in pretty good shape at this point. And then a distal fixation and syndesmotic fixation, screws in this situation, just because older patient, not as good a bone, facilitating additional fixation with 3 of the distal interlocks. And then I think what I'll just remind you is, because I kind of forgot, is this had that big segment, that big butterfly segment proximal. So Bethany, I don't know if there was more than what the picture showed, but I mean, did you take the clamp off and see what that did?
Yeah, so I took the clamp off and it bounced out, like the butterfly displaced out. So I was like, damn it. So I put the clamp back on, and at that point I'm like, hopefully this works, otherwise we'll have to pull this out potentially. I put a secondary screw, and the nail's so tiny you have a little bit of room in there around it, so I put like a 2-0 screw into the butterfly.
I like that. It almost looks like a blocking screw.
That's what I was going for.
It held it nicely,
right? Because you put it on afterwards. But I mean, I like that. That's I mean, you're right. You had plenty of space there.
Yeah, I mean, she had capacious canal essentially, and not that great a bone, so she had more room in there, obviously, for that.
And here's your post-ops, which I think look great. These are probably 3 months or so, I think. Mortise looks good. Looks like it's healing, assuming the skin and soft tissues are healing well. And I think that's a big win in this setting, especially if you're concerned about wound healing.
Yeah.
Do those distal screws lock into the nail?
No, I don't think so.
I think some of them that have like the end cap, like the Arthrex, you can lock it in because the end cap will lock into that distal screw as long as they don't drop the end cap on the floor, which has happened to me.
I'm sure it's a very small.
I do feel like overall there's so much room for advancement on this implant, because we've talked before, like you can, what do you want to use this on? Poor bone quality, poor host, poor comorbidities, whatever. Well, I would like to have more larger syndesmotic screws for those people. So, and a little bit larger fixation or better fixation.
You're talking about distal?
Yeah. Just in life in general.
Yeah, I agree. We've talked about that before, like having more, the pore diameter of the syndesmosis screws, or even 4 or 5. I mean, something a little bit bigger, because you're right that this is a situation where oftentimes bone quality is not that good.
I just don't think you would, I wonder if one of the concerns is that you would weaken the nail, but these nails don't see a tremendous amount of load. Like they're not like the femur or the tibia.
Right.
So even if you put a larger aperture for the screw hole, for the screw, I don't think, I have not seen many of these break. I see them fail, but I don't see them break.
Well, I see them fail at the syndesmosis. So fix that portion of it, because that's where the fracture heals, but the syndesmosis widens.
Yeah.
So there's a question in the chat: how many degrees of angulation can you get? I mean, I think I think most of these are kind of locked in, so you don't get any. But I can't comment on the Paragon, but I assume that, what did you say, Jan? That was maybe 20.
Yeah, I was looking at it right now. I was looking at their technique guide, and I think they have it with their flexible device. They said like otherwise you have to use like a screw. Oh, he has it right there, 22, 27, and 32. So there's some variation. Doesn't seem like a lot, but I'm not sure how much you need.